দিনে ছাড়া যাওয়ার দরকার নেই।
Yeah, hi, good morning. Hi, good morning, Dr. Poonam.
Good morning, ma'am. Tirtha here, ma'am.
Yeah, hi, Tirtha. I am ready whenever.
Yes, ma'am. We'll start.
In
Poonam
15.
madam will start the class, ma'am.
Can we or should we wait? Is any?
Ma'am, we need to wait for another 5 minutes, ma'am.
No problem, no problem.
Hello.
Yeah, hi.
Hi, good morning. I'm Dr. Poonam here.
Yeah.
This is another session for our Saturday ACTREC academic classes. And today is our speaker is Dr. Katha Gavade. Dr. Katha is Associate Professor in Department of Pathology. And she'll be speaking on the histological classifications of laryngeal and hypopharyngeal cancer. So, Dr. Katha, I welcome you for today's lecture. Please go ahead.
Thank you so much, Dr. Poonam, for the kind introduction. Should I wait for a couple of minutes for other people to join?
Please go ahead. They will keep on joining. So you please go ahead.
Yeah. Okay. I'll share my screen then. Is my screen visible? Full screen?
Yes, it is.
Okay. So good morning, everybody. I'll be discussing histological classification of laryngeal and hypopharyngeal cancers, the pathology aspect of the laryngeal tumors that we so often see in Tata Hospital. I will start with, the surgical anatomy, very basic. So larynx is a tubular organ which is from the epiglottis to the cricoid cartilage, and it is divided into three parts: supraglottis, glottis, and subglottis. Each part has a definite clinical significance. That is why the tumor staging of laryngeal cancers is done based on the site of the tumor in the larynx. Larynx has 9 cartilages, 3 of which are paired and 3 are unpaired. So like I said, larynx is divided into supraglottis, which is up to here, which consists of the epiglottis, aryepiglottic fold, the arytenoids, and the false chords. The true chords comprise the glottis, and beneath it is the subglottis. So the supraglottis has a very rich lymphatic network. So any tumor which is epicentered in the supraglottis will have propensity for more nodal spread. Glottis has no lymphatics, hence there is only local spread that is often seen in glottis and subglottic tumors. It infiltrates first to the adjacent structures and will then go to the nodes. Hypopharynx is the part behind the larynx. It starts from the superior border of the hyoid bone and extends up to the cricoid cartilage, and it comprises of both the bilateral pyriform sinuses, the lateral and the posterior hypopharyngeal wall, and the postcricoid region. So the TNM staging for laryngeal and hypopharyngeal cancers is divided based on the specific subtypes. So for all supraglottic, glottic, and there is a commonality in all staging of all these 4 regions: glottis, supraglottis, subglottis, and hypopharynx. So TX's tumor cannot be ascertained or assessed, and TIS is carcinoma in situ. So T1, T2 are T1 are those tumors in all the 4 subsites that are limited to one specific subsite of that region, subsite of a supraglottis or just vocal cord of the glottis, or subglottis and hypopharynx. T2 are those which extend to more than one subsite of that region, but do not show vocal cord fixation. When there is vocal cord fixation, the tumor becomes a T3 tumor. Also in T3 tumor, there is involvement of the pre-epiglottic space that is in front of the epiglottis and the epiglottic cartilage, the fatty tissue that is present there, the paraglottic space, and the inner cortex of the thyroid cartilage. T4 tumors are divided into T4A and T4B. And these are T4A are those which extend beyond the larynx, that is to the outer cortex of the thyroid cartilage or to the soft tissue of the neck.
Hello. Dr. Katha, you are not audible. Hello.
Okay, sorry. So was I not audible throughout?
No, just the last 1 minute.
Okay. So like I said, T1, T2 are those tumors which are early stage tumors and are limited to the larynx. T3 tumors are also limited to the larynx, but invade pre and paraepiglottic space as well as the inner cortex of the thyroid cartilage. T4 are those tumors which extend beyond the larynx and divided into moderately advanced and very advanced laryngeal tumors. In the hypopharynx, apart from the T staging based on the subsite and the fixation of the vocal cord and involvement of hemilarynx, it is also based on the size of the tumor. A size less than 2 centimeter is a T1 tumor, 2 to 4 centimeter is a T2 tumor, and T3 is a tumor, which is larger than 4 centimeter in the greatest dimension. And T4, like in larynx, is moderately advanced and very advanced local disease. For end staging of head neck tumors is common for all head neck tumors, including oral cavity, larynx, hypopharynx, etc. It is just divided as this nodal staging is for tumors which are P16 or HPV negative and EBV negative tumors. So it is from NX to N3B. N2A and N3B are the important end stages because N2A and N3B have extranodal extension. Single node, which is less than 3 centimeter, showing extranodal extension, will be staged as PN2A. and multiple tumors or a tumor that is greater than 3 centimeter, multiple nodes or any node that is greater than 3 centimeter with extranodal extension will be staged as N3B tumor. So the type of specimen that we receive are near total laryngectomy, total laryngectomy. These are done for advanced laryngeal cancers, that is those that are usually T3 and T4A tumors. Laser excision or partial laryngectomy is reserved for carcinoma in C2 or T1, T2 glottic, supraglottic cancer. So this is just some photographs of T3 tumors. T3 tumors of the supraglottis, which are showing invasion into, which can either show invasion into the paraglottic, pre-epiglottic space, pre-epiglottic space, or invasion of the thyroid cartilage. This is glottis, again with vocal cord fixation. This is subglottis with vocal cord fixation. So tumors that involve the paraglottic space or the preglottic space are designated as T3 tumors. This is supraglottis, glottis, and subglottis tumors, which are T4A. So T4A is extension of the thyroid of the tumor into either the thyroid gland, the outer cortex of the thyroid cartilage, esophagus, or a base of the tongue, extrinsic muscle of the base of the tongue, strap muscles, etc. So this is the specimen that we receive in our frozen section. We cut it on the posterior aspect. This tumor is located in the glottis, an ulceroproliferative tumor. This is the epiglottis, and this is the lower end, which is a tracheal end. Another tumor, which is in the pyriform sinus. This is a tumor which has been fixed overnight, and this was inked on the posterior aspect by the Grossing pathology resident. So this is the inked specimen, and the margins we take are 5 mucosal margins. Epiglottis margin, the anterior part of the epiglottis is the anterior margin. The 2 margins towards the pyriform sinuses are the right and the left lateral pyriform sinus lateral mucosal margins. The tumor here is in the glottis, and this is the posterior margin. So this will be the posterior inferior margin, which is towards the pharynx, and this is the inferior tracheal margin. After the specimen is fixed overnight, the next day the specimen is sectioned from superior to inferior end. This is how we section the tumor, and we divide it into right and left halves. Then all the sections that we have taken from that laryngeal specimen, we place them on our table, and we assess where the tumor is and where it is infiltrating the most. So we look for whether it is involving the supraglottis. So here it is the glottis and the subglottis. So the anterior most part, we had taken the anterior epiglottis cut margin, and the inferior most part will be the tracheal cut margin. Other lateral and posterior inferior cut margins are taken before slicing the specimen. This tumor is in the glottis and is invading the thyroid cartilage here. So sections are taken accordingly, which are most representative of the tumor. So tumor here in the supraglottis as well as the glottis. So this is going beyond the thyroid cartilage into probably the strap muscles. This is a thyroid gland that looks brownish red after fixation. And this is the subglottis. So this was basics of what the laryngeal anatomy, the hypopharyngeal anatomy, and how we grow the specimens for better understanding of classification and reporting of laryngeal tumors. So laryngeal tumors are classified based on laryngeal as well as hypopharyngeal, have precursor lesions which are papillomas or epithelial dysplasia, which can be low-grade dysplasia or high-grade dysplasia, and carcinoma in situ. Among the malignant tumors, most common is the squamous carcinoma, which has varied subtypes. Other tumors which are extremely uncommon include neuroendocrine tumors, salivary gland tumors, some mesenchymal tumors which arise from the cartilage of the larynx, which is chondroma and chondrosarcoma, melanocytic tumors, hematolymphoid tumors. These are extremely rare and have just few case reports. So we will discuss squamous carcinoma. So this is the section of a normal laryngeal normal larynx. So this is the epithelium that you see. This is the subepithelial tissue or the submucosa. This is the cartilage, and this right here are the strap muscles. So this was the epithelium. So epithelium can be squamous epithelium, which is seen more in the superior part of the larynx, and respiratory epithelium. As you go down towards the trachea, you will start seeing respiratory epithelium. In the submucosa, there are a lot of these glands. These are normal salivary glands, and from here arises salivary gland tumors in the larynx. These are minor salivary glands. This is the cartilage. Cartilage can show this bony ossification a lot of times, especially in older individuals, and tumors may arise from the cartilage or the bone, which is very, very extremely rare. And here was a strap muscle. So this is a normal squamous epithelium, and there is a tumor right beneath here. Very busy looking subepithelial tissue. This is the superficial epithelium, and there is a tumor which is arising from here. So these are the squamous cells, and these are the squamous nest which are going beneath the normal epithelium. So this is what we call stromal invasion. When we say that we cannot see stromal invasion in the biopsy specimens, it is because we get usually tumor which is very proliferative and there is no stromal tissue for us to comment on. So a diagnosis of squamous carcinoma can only be made with evidence of stromal invasion. So these are the nest of squamous epithelial tissue, squamous carcinoma. This is what we know as keratin pearls, which are seen in moderate or well-differentiated squamous carcinomas. So apart from squamous carcinoma, conventional type, we have various subtypes of squamous carcinoma, which are not very often seen, but can be seen. This is a verrucous carcinoma, which will not show those nests or islands of squamous. These are small islands, small nests. We describe them as nests of atypical squamous cells. These are not seen in verrucous carcinoma. This atypical epithelium just dips down into the subepithelial tissue, and that makes the diagnosis of a verrucous carcinoma. A lot of times, squamous carcinoma comes in the form of papillae. So a papillae is anything that has a central vessel core. This red is the RBCs. So there is a vessel in between, and it is lined by atypical squamous cells. That is a papillary squamous carcinoma. So these tumors are usually proliferative and exophytic and detected early. So may present as early stage cancers. This is known as a lymphoepithelial carcinoma. It is a subtype of squamous carcinoma, but it has a lot of lymphocytes. So as you can see, there are these small blue cells. These are all the lymphocytes that are seen, and the larger ones, a bit paler, are the tumor cells. So the tumor cells are often masked because of the extensive chronic inflammatory cells, that is the lymphocytes and the plasma cells. This type of tumor is most often seen in nasopharynx and known as the nasopharyngeal carcinoma. This is another subtype which is showing squamous differentiation as well as some gland, some lumen here, which is known as glandular differentiation. We call these type of tumors as adenocarcinoma. So this is a adenosquamous carcinoma. Another type of tumor, subtype of squamous carcinoma, is a basaloid tumor. So if you can notice in the upper section, the tumor cells look very pink. So lot of cytoplasm. In basaloid, they are very blue looking tumors. So this is known as a basaloid carcinoma. But again, in basaloid squamous cell carcinomas, you will find keratin pearl somewhere, a proper focus of keratinization, which will aid in diagnosis this as a squamous carcinoma rather than any other carcinoma like a salivary gland carcinoma or a basal cell carcinoma. This is another tumor, which another subtype, which shows a very spindled morphology, almost like a sarcoma. So this is a spindle cell variant of squamous carcinoma. So for diagnosis of this, we have to demonstrate positivity for cytokeratin or any squamous epithelial marker. In view of absence of this, and if all the markers for a sarcoma are negative, in a mucosal site, this morphology is most often consistent with a spindle cell variant of a squamous carcinoma. So the papillary, verrucous, and the lymphoepithelial carcinomas have a little better prognosis than the conventional squamous carcinomas. And these on the lower row, which is the adenosquamous, basaloid, and spindle cell, fare poorer and have a more aggressive course than conventional squamous cell carcinomas. So there are different parameters that we report in a surgical pathology report, some of which are core elements which have to be mentioned and which are important for further management of the patient after the report is generated. So first of all, what operative procedure was performed, what specimen was received to us, the specimen dimension, the focality of the tumor, whether there was just one tumor or there were multiple tumors that we saw, the dimension of the tumor. So in larynx, the dimensions don't matter so much, but in other head neck tumors, head neck subsites, the dimensions are of prime importance. And the location of the tumor. After all this all is done in the grossing room. That is when the specimen is cut and given for further sections of hematoxylin and eosin. That is further processing. After the slides are received by us, we document the histologic tumor type, whether or not it is a squamous carcinoma. If not, then what? So if not, then we have to perform some IHC markers, which give us which will give us a definitive diagnosis. The grade of the tumor. So by grade, I mean how much does this tumor resemble the normal epithelium? So if it resembles a normal epithelium perfectly well, then we call it a well differentiated squamous carcinomas. The lesser it mimics or is identical to the normal squamous epithelium, it will be a poorly differentiated carcinoma. And anything between that is a moderately differentiated carcinoma. Apart from the histologic tumor type and the grade, we have to document the perineural invasion. This is a nerve that is seen, and this is a tumor around it. So there is perineural invasion here around the nerve. This is a big vessel and there is a tumor embolus here. So this is what we call lymphovascular emboli. The margins of the tumor, whether these margins are free or they are involved by tumor. If there is invasive carcinoma, we need to document that. The distance from the invasive carcinoma, if there is any discrepancy between the gross and the microscopic margin, then we mention that on the report. If there is carcinoma in situ at the margin, high grade or low grade dysplasia, we also mention that. Then this is extension into the pre-epiglottic pad of fat. So this vacuoles are the fatty tissue, adipose tissue, and tumor is infiltrating into this. So this is documented as extension into the pre-epiglottic pad of fat. And this is a larynx. This blue structure that you see down here is a larynx, and these are squamous pearls. So this tumor is infiltrating into the laryngeal cartilage. So this is larynx here and larynx here, and tumor is right in the middle of it. So this is a definitive evidence that the laryngeal cartilage is involved by the tumor. Next is the involvement of the thyroid gland, which is present. These are the thyroid follicles that you see, these round structures, and there is tumor on the right side, which is coming into the thyroid gland. And this is extralaryngeal strap muscle invasion. So this long structures are the muscle fibers, and there is tumor here on the right side. So extralaryngeal strap muscle thyroid involvement will warrant a diagnosis, a staging of PT4A. After the main tumor is examined, we sample, all the nodes are sampled, which we report as whether or not there is metastasis. If there is metastasis, what is the size of the metastasis? If there is, if the metastasis is whether or not it is limited to within the capsule of the lymph node. If it is outside the capsule, we also document the extranodal extension, whether it is more than 2 mm or less than 2 mm, or if we can specifically give the size of the extranodal extension. This is the capsule of the lymph node, sorry. And this is the fat which is outside the lymph node. The tumor has gone into the fat. So there is extranodal extension of the tumor within the extranodal fatty tissue. In contrast, on the right side, the tumor is all limited within the node, within the capsule. There is a thin rim of these blue cells, which are lymphoid cells. So tumor is within this. So after squamous carcinoma, the next common carcinomas, tumors of the larynx are neuroendocrine tumors. These are also extremely rare, but they come next to squamous carcinomas in their frequency. And in a span of 12 years, we have just reported 27 to 30 laryngeal neuroendocrine tumors, which it was a study was done by Dr. Munita Bal. So between 2005 and 2017, 27 laryngeal neuroendocrine tumors were reported at our institute. So these tumors arise from the neuroendocrine cells. So where are these neuroendocrine cells located? Within the respiratory epithelium and the squamous epithelium, there are usually within the respiratory epithelium, there are small neuroendocrine cells dispersed within it. These are not visible to naked eye, but they can give rise to neuroendocrine tumors. Neuroendocrine tumors are those that express neuroendocrine markers. So apart from cytokeratin, they will express synaptophysin, chromogranin, INSM1, CD56, etc. They are divided into well-differentiated neuroendocrine tumors, and neuroendocrine carcinoma. So amongst the tumors also, they are divided into grade 1, 2, and 3. 1 is the most low-grade tumor, which will have less than 2 mitosis and no necrosis. Grade 2 and 3 are based on increased mitotic index, that is 2 to 10, and necrosis. More than 20 mitosis is more than 10 mitosis is grade 3, 2 to 10 is grade 2. Neuroendocrine carcinomas are very high-grade carcinomas. This is a picture of a neuroendocrine tumor. So we can see very uniform-looking cells, and they form like sort of ribbons, and the pattern is like ribbons and festoons that we call, and very bland. They look the nuclei look identical to each other. So very benign-looking, very low mitotic index these tumors have. In contrast, neuroendocrine carcinomas will look high grade. These are all high grade tumors showing pleomorphism, very, very blue looking nuclei, brisk mitosis, lot of apoptosis. So they are divided into small cell and large cell neuroendocrine carcinomas, small cell of which is much more common than large cell neuroendocrine carcinomas. These are large cell neuroendocrine carcinomas, which large cell because the small cell, because they have very less cytoplasm, the nucleus occupies most of the cytoplasm, so they are known as small cell neuroendocrine carcinomas. They have a very blue hyperchromatic nucleus and very high mitotic index. The large cell neuroendocrine carcinomas will give an appearance of pink looking tumor cells because they have some amount of cytoplasm, which is lacking here. In contrast to these blue looking nuclei, here the nuclei are more pale. of pale looking vesicular, we call them, and they will show a prominent nucleoli. So these were the common tumors that we saw in larynx, which were most often operated for total or near total laryngectomy. Now we move on to laser excision, which is done for early glottis cancers. The specimen we receive that you send to us is a small specimen and margins are marked. This is usually done for T1 tumors and T2 tumors. So T1 tumors, again, where it is located in only one site of supraglottis, glottis, or subglottis, and T2 where it extends but to another subsite, but there is no vocal cord fixation. This is how we receive the specimen. Margins are labeled by the surgeons for us. After we receive it, we ink it with different colors. So green, blue, purple, and anterior will be is orange. This color coding is written on the paper for ease of the reporting pathologist to understand which margin is colored in which color. Then we sample the section as anterior to posterior. So anterior and posterior will be a shave margin, and these are radial margins. So a radial margin is a one in which you can see a tumor and a margin next to it. So we can document the distance of the margin from the tumor on histopathological section. So apart from T1, T2 invasive squamous carcinomas, other lesions that are excised by laser excision are dysplastic laryngeal lesions, which this is a mild dysplasia. This is mild or low grade dysplasia. So there is irregularity of this epithelial cells only in the lower half. This irregularity of the epithelial cells extends to the upper part of the epithelium. This part is the epithelium. This is the basement membrane. And this is known as high grade or low grade and high grade dysplasia. And this is superficially invasive squamous carcinoma. So this is a normal epithelium that you see. And this tumor is going beneath the normal epithelium, but it is only extending up to 0.1 or max 0.2 centimeters. So we have covered squamous carcinoma, subtypes, and neuroendocrine tumors, and also covered epithelial dysplasia. For salivary gland tumors and mesenchymal tumors are very rare tumors. Amongst the salivary gland tumors, adenoid cystic carcinoma, mucoepidermoid carcinoma are the commoner ones, but they are rarely seen, so I will not be discussing these tumors. Amongst mesenchymal tumors, chondroma is atypical cartilaginous tumor, and chondrosarcoma is again atypical cartilaginous tumor, but it is a malignant chondroid tumor, which will show a large size, necrosis, invasion of the adjacent structures, etc. Melanocytic hematolymphoid tumors are again very, very rare. Another category that comes is metastasis, which is also very rare in larynx, but needs to be considered, or direct extension of the tumor from another subsite, like a thyroid tumor or a esophageal tumor or a tracheal tumor. Now, this is the last precursor lesion that we will discuss. It is a squamous papilloma. So again, like I told you, this is a papilloma or papillary squamous carcinoma, where I use the word papillae, is any lesion which shows these fibrovascular cores. Now, in this case, the vessel is not prominently seen, but fibrovascular core and the lining squamous epithelium. In a papilloma, the lining squamous epithelium is very bland, usually. High-grade features are uncommon and usually seen in recurrent tumors. These express squamous epithelial markers, but are negative for P16 because they are associated with low-risk HPV 6 and 11, low-grade HPV. And malignant transformation is also seen in 1 to 4% of the cases only. So important points that need to be taken from a histopathology report is documentation of dysplasia at the margin, whether it is high grade or low grade. High grade dysplasia is reported as a positive margin. Positive margin is the one where you see a high-grade dysplasia, you see carcinoma in situ or invasive carcinoma at the margin. So at the margin is where we ink the tumor, that margin. Where we ink the margin, sorry, where the black ink is seen on the microscopic section. If there is a tumor or high-grade dysplasia at that level, we call it a positive margin. Close margin is not yet standardized, but 2 mm is considered, less than 2 mm is a close margin for glottic larynx, and others 5 mm like other head neck tumors. The presence of perineural invasion is also associated with poor local disease control, as well as lower disease specific survival and overall survival. So that needs to be documented in every report. Thank you. And these are some of the references, photographs which I used.
So, thank you so much, Dr. Katha. It was an excellent presentation. Dr. Katha, hello.
Yes, ma'am.
Yeah. So I think the main reason why I included this class for today's presentation is that we most of the time, usually 95% of the time, our patients are squamous cell carcinoma patients.
Yes.
And for us also and for our residents also, they usually are not aware of the other histology. So I'm thankful to you that you told us the various histologies. In fact, in squamous cell also, like the adenosquamous, the basaloid,
Yes.
which we all see very often, but these are the spindle cell carcinoma, the spindle cell variant. So these are very not that common histopathologies. And moreover, the salivary gland tumors, the neuroendocrine tumors, and there are certain peculiar clinical characteristics which the resident should be aware when dealing with the laryngeal cancer. So, just because I have collected a data of around 30 patients of our rare tumors of larynx, where I had the experience, and we have seen that our these hello.
Yes.
So these minor salivary gland tumor patients, usually they have a submucosal lesion as compared to our squamous cell carcinoma patients, where the lesions are usually more proliferated. So, yeah, they are more proliferated, exophytic, as compared to our minor salivary gland tumors. And in fact, I think spindle cell carcinoma, we see more of pedunculated lesions. They are more of our clinical information, and they usually radiology by surface. So just to reiterate the fact which Dr. Katha also said, already said, is that we have to be aware of the various histologies because the treatment might change accordingly. So, Dr. Katha, I think there is one question, if you could please take that.
Sure.
How could you clarify more about the PNI, the layer invaded, and the size of the nerve involved?
Okay, so PNI is perineurium. So there is a epineurium and a perineurium around a nerve. There are nerve fibers and there is a perineurium. If I can go back to the slide, let me. So here, this is a nerve. Can you see these nerve fibers, these small, these are the nerve fibers. And this layer just around it is the perineurial perineurium, which when invaded is reported as perineurial invasion. There are times when there is intraneural invasion of the tumor also, but it is not found to be so significant. However, when present is reported. And the size is reported as less than 1 mm and more than 1 mm. So less than 1 mm are small caliber nerves and more than 1 mm are the bigger nerves. So that bigger nerves becomes more important for, I think, local control or loco-regional control. And we also document whether it is focally invading, focal perineurial invasion or extensive. There is no criteria to call anything focal or extensive. But when we see more than 4 or 5 nerves that are involved in the tumor, we call it extensive perineurial invasion.
Yes. And we know that PNI per se is an independent risk factor for poor prognosis. So it is very important that you basically the major PNI would be more important here to know, and it will have a direct effect on the prognosis of the patient, and they usually need an adjuvant radiotherapy for the further treatment.
Yeah,
So if there is any other question
I'll be happy to
from
take.
the residents. Importance of dysplasia at margin.
So high grade dysplasia, high grade dysplasia is full thickness dysplasia. So that is associated with local recurrence. So that is the importance.
Dr. Katha, one more thing, like we are very sure that if it is a mild dysplasia, I think the question is like that. We know that we can observe it. You already said that. When it is a
High grade
severe dysplasia, carcinoma, and CT, we usually feel excited. But
Yes.
what about the moderate dysplasia? What should we do in that case?
So high and low grade dysplasia, moderate and full thickness mild, moderate and severe dysplasia. So mild is called as low grade dysplasia, moderate and severe is called as high grade dysplasia.
Okay. I think there is some inter-observer variability also, and I think for moderate dysplasia, the inter-observer variability is high. I think that's why they have kept moderate and severe dysplasia together.
Together, yes.
Okay.
So instead
for-
of 3-tier, 2-tier becomes simpler
Right.
to take care of the inter-observer period.
Correct. So from the clinician point of view, if it is a mild dysplasia or low dysplasia, like Dr. Katha said, we'll be just observing, while if it is a moderate to severe dysplasia, we'll be excited or we'll be teaching the patient.
Yes.
So if there are any other questions?
So just one thing, can I just add that there is one EQUAS program that we run from our department, external quality assurance program. So there are more than 150 centers all across the country that participate in that program. And we send small biopsies also for reporting to see how the performance of other labs is. So these include cancer institutes and non-cancer institutes, whoever want to participate. So in the last 2 years, we had sent oral cavity, not larynx or oropharynx, oral cavity to big specimens as in the slides of oral cavity squamous cell carcinoma. And we just saw the performance. So the documentation of, like you said, margins, dysplasia is not very good. So our aim is to teach those institutes. So after we receive their report, we just write back to them what all needs to be included, what are the core elements that are there in a reporting of a large specimen. So PNI, the same doubts that we discussed today are discussed with other participants, so that all across the country cancer reporting can be standardized and uniform. Thank
Yeah, that is a great idea, and I think that we all have to do it. That is the way to do. So with this, I thank Dr. Katha for an excellent presentation and bringing forth to our notice and to our to inform us that there are so many various histopathologies, and a close collaboration between a clinician, surgeon, and a pathologist is a must to treat the patient in the best possible way. With this, we conclude today's lecture. Thank you, Dr.
Thank you so much, Dr. Poonam. It was a pleasure.